Good afternoon, everyone. I'm Andrea Lavario, Senior Public Policy Advocate with the Human Rights Campaign. On behalf of HRC and the Center for Health Law and Policy Innovation of Harvard Law School, welcome to today's webinar, Advocating for and Advancing Access to PrEP. In June 2019, the U.S. Preventive Services Task Force recommended that pre-exposure prophylaxis, or PrEP, be covered by health plans without cost sharing. The recommendation did not address ancillary services like routine testing and monitoring required for patients taking PrEP. This past July, the Department of Health and Human Services issued guidance clarifying that, and I quote, PrEP is a comprehensive intervention comprised of antiretroviral medication and essential support services, end quote, and that the latter must also be covered without cost sharing. In this webinar, we will update you on the HHS guidance and how it is being enforced, what states are doing to help patients and providers understand the changes, what advocates can do to help those who encounter barriers in accessing PrEP, and the advocacy efforts underway to expand access to PrEP and how you can engage in those efforts. Now I'd like to introduce our panelists. First, we have Marianne Tomaszak. She is a clinical instructor at the Center for Health Law and Policy Innovation of Harvard Law School. As a public health lawyer, her work is focused on healthcare policy, private health insurance, healthcare non-discrimination, and access to gender-affirming and sexual and reproductive healthcare. Prior to law school, Marianne worked at the intersection of healthcare reform and reproductive justice at Raising Women's Voices. She served as an elected official on a board of education and volunteered as an emergency medical technician for many years. Marianne's work is also informed by her experience growing up in an immigrant family and her academic training from Boston University School of Law, Columbia University's Mailman School of Public Health, and Swarthmore College. Nadine Israel is the Vice President of Policy and Advocacy at AIDS Foundation of Chicago. For the past decade, Nadine has been engaged in the health policy and advocacy work in Illinois, working closely with other activist leaders across the state on issues impacting the Medicaid program, Affordable Care Act, mental health and substance abuse system, housing, and state budget and tax policy. Nadine previously served as the Director of Policy and Advocacy at EverThrive, Illinois, where she led the organization's policy development and implementation efforts on issues focused on maternal and child and adolescent health. One of Nadine's proudest accomplishments in her state-level advocacy work was collaborating with health policy leaders to successfully advocate for legislation expanding the Illinois Medicaid program, which granted access to healthcare to an estimated 650,000 Illinoisans experiencing financial hardship. She holds a Master of Arts degree from the University of Chicago School of Social Service Administration and a Bachelor of Science from the University of Illinois at Urbana-Champaign. Lindsay Murtaugh is the Director of the Market-Wide Regulation Division within the Oversight Group at the Center for Consumer Information and Insurance Oversight, CISIO, at the Centers for Medicare and Medicaid Services. Prior to this role, she served as a senior policy advisor for CISIO after practicing health regulatory law. Lindsay has a master's in public health and a law degree from Harvard. Kara Cheevers is the Director of Behavioral Health Programs at the Colorado Division of Insurance, where she works to ensure Coloradans have access to quality and affordable mental health and substance use disorder coverage. Before joining Colorado state government, Kara served as the policy director at One Colorado Education Fund, working with community members and coalition partners to improve the lived and legal experience of LGBTQ Coloradans and their families. Kara has also served as the deputy director of Serve Colorado, the Governor's Commission on Community Service, managing a multi-million grant-making process to develop evidence-based AmeriCorps state programs to support poverty alleviation programs. She is a very proud alumnus of AmeriCorps, having served 2 terms to address issues related to housing insecurity and homelessness in rural Colorado. Kara holds a Master of Social Work from Washington University and a Bachelor of Social Work and of Spanish Language from Western Michigan University. Welcome to our panelists. So before we get started, just quickly for folks, if you wish to ask a question, please use the chat box. And I'm going to start off our questions today with having Lindsay share with us what exactly the new guidance from HHS is and what does it mean with regard to PrEP services.
Thank you. And before I get started, I have to give a standard disclaimer as a government employee. So I just want to say, to the extent I misspeak and anything I say, is inconsistent with the guidance or regulations or statute, that obviously controls not what I said on this call, although I will do my best to represent it accurately. And in addition, any views I represent on this call are my own and not that of the federal government. So with that out of the way, let me jump into the actual guidance. First, I should give credit where credit's due, and we may talk a little bit more about kind of why, but it wasn't just HHS that released this guidance. We released this guidance with the Department of Labor and the Department of Treasury, and that's because we all shared jurisdiction here. So if we talk about enforcement, we may want to cover that, but I don't want to get too far ahead. Anyway, we released this guidance, and it's implementing or clarifying the requirements for private plans and issuers under Section 2713 of the Public Health Service Act. And the way that section works, it basically says that plans and issuers have to cover certain preventive services with zero cost sharing. And it doesn't leave the decision of what preventive services are up to us regulators with no clinical experience. Instead, it points to certain other bodies that do evidence-based kind of analysis or evaluation of the different preventive services and decide whether to come out with a recommendation. So in this case, or for example, one of the types of services that has to be covered is anything with an any evidence-based items or services that have an effect, a rating of A or B from the United States Preventive Service Task Force, or USPSTF. And so whenever the USPSTF comes out with a new recommendation, that will mean that plans and issuers will have to cover with zero cost sharing whatever is covered under that recommendation with respect to the individual described in the recommendation. So on June 11th, 2019, the USPSTF came out with a new recommendation related to PrEP. And as a result of that, that's what triggered this new coverage requirement for plans or issuers. So generally, they have basically a year from the time the recommendation comes out to sort of round up. So it's a year from kind of the end of the month in which the recommendation was issued. And plans and issuers after that have to start covering it. So in this case, plans and issuers were required to start covering PrEP with zero cost sharing for plan years that began on or after June 30th of 2020. Now, as this began to go into effect, we heard from a lot of stakeholders that they were concerned that PrEP was being covered improperly by plans and issuers. And so if you look at the recommendation that the USPSTF came out with, it's really easy to focus just on the very top line message. And that top line message, and I wrote it down here so that I could quote it directly, just says that it's a recommendation for effective, sorry, I lost where I wrote it down. Hold on one second. I'm so sorry. I tried to be prepared and then I moved my screens around. So it just says that it recommends that clinicians offer PrEP with effective antiretroviral therapy to persons who are at high risk of HIV acquisition. And that focus on antiretrovirals is what I think caused a lot of confusion, and what we heard from advocates is really causing problems as it rolled out. As those of you who are familiar with PrEP understand, PrEP is not just the drug. It includes all the additional services, and those additional services are really key to PrEP's efficacy and effectiveness. And so when you look then beyond that top line recommendation from USPSTF, the recommendation statement as a whole, I'm sorry, are folks having trouble hearing me? Okay, sorry, whoever just dropped that in chat, I don't think most people are. But so when you look at the recommendation statement as a whole, you look beyond that top line message, the recommendation statement goes into much greater detail about what PrEP really is. That recommendation statement discusses the CDC guidance, and the guidelines around PrEP that the CDC has issued advise that PrEP is, as Andrea said, a comprehensive intervention comprised of antiretroviral medication and also those essential support services. So those include things like medication self-management, adherence counseling, risk reduction strategies, and mental health counseling. And when USPSTF looked at PrEP, they looked at all of that. They didn't look at the antiretrovirals in isolation to determine whether or not that was effective. They looked at it as a whole. That's what all the studies are. They don't take, the studies for PrEP don't take just the drugs and say, oh, is this effective? They look at the way the intervention is delivered in practice. And so the recommendation really talks not just about the drugs, but it talks about the CDC guidelines and then includes all the services, the baseline and monitoring services that are described in the CDC's guidance as well. And that those services are essential really to PrEP. And so what we did in the guidance is clarify and reiterate guidance we've offered in the past, that it's really the recommendation statement as a whole that needs to be looked at, not just that top line message. And we called out certain items and services that are described in the recommendation statement, but ultimately plans and issuers should be looking to the recommendation statement, not just to our guidance. I think what we did in our guidance was really draw attention to certain services that are mentioned in the USPSTF recommendation, but ultimately that's kind of the core for like what the requirement is. And just to describe a few of the items and services that includes, it includes things like HIV testing, hepatitis B and C testing, pregnancy testing, testing for STIs and screening and counseling related to that, adherence counseling. But these services, as many of you know, are really key aspects of PrEP and are really important for ensuring that PrEP is delivered to at-risk individuals who are not infected with HIV and who don't have medical contraindications, and that they continue to be monitored and supported as they receive PrEP. Let me make sure I call out a few other things that we mentioned in the guidance. We also reiterated some prior guidance, or actually the standard is in our rules about when office visits associated with receiving a preventive service have to be covered. And then we also talked a little bit about medical management, and here we applied some general principles that apply under to all preventive services, to PrEP in particular. So if you look at the recommendation statement, well, let me back up and talk about the standard quickly. Plans and issuers are allowed to apply certain medical management techniques, or their reasonable medical management techniques, to preventive services when they cover them. However, there's some limitations on what they can do. So if, for example, the recommendation describes the frequency with which certain services need to be provided, the planner assured can't then go and apply additional medical management techniques that would limit the frequency in a different manner. And if you look at the USPSTF recommendation, there are certain recommendations about the frequency with which some of these monitoring services need to be provided. So we emphasize that a planner sure can't apply additional limitations on top of that. They have to look to the frequency specified in the recommendation. We also noted that where PrEP is medically appropriate for an individual as specified in the recommendation statement and as determined by the individual's healthcare provider, it's not reasonable for a planner issuer to restrict the number of times the individual may start PrEP. And we heard from advocates as we developed the guidance that that's one of the really important things about PrEP, that starting and stopping may be very appropriate for the individual. It's not, for a lot of people, it's not a lifelong type of thing. It's you start, and then when it's appropriate for you, when you're at high risk, and then that relationship ends, you might stop it, that sort of a thing. And so we emphasize that in the guidance. We also had received a lot of questions about brand drugs versus generic drugs, and I think I may be getting the timing off, but I think generic came out after the recommendation statement, but anyway, it was all kind of coming around the same time. And so under our rules, a plan or assured can, say if there's a generic available, they can apply some medical management to encourage folks to take the generic over the brand. But if that if the generic's medically inappropriate as determined by the healthcare provider, they need to, have a mechanism in place to allow an individual to get the brand version or non-preferred brand version. And then finally, and I'm almost done with the requirements, but finally, the other thing we mentioned or emphasized was that if the planner assured does use some sort of medical management technique, they have to have in place some sort of easily accessible, transparent, and sufficiently expedient exceptions process. So there needs to be some mechanism through which an individual can kind of I don't know if challenge is the right word, but get access to the service.
That's very helpful.
And I think I'll turn back. Yeah.
That's very helpful to clarify where things stand and what folks can expect. For the advocates who are on the panel today, what challenges, if any, have you heard or seen in ensuring appropriate access to PrEP since the release of the federal guidance? And I'll just sort of tee that up for the other panelists to weigh in on that.
I'm happy to jump in. First, I just want to say thank you to Lindsay and anybody at CMS that worked on this FAQ, because since PrEP became a grade A preventable service, we have been in Illinois, the HIV advocates, communicating with our Department of Insurance and our governor's office at the time to to send like a bulletin, basically to ask for communication from them to the insurers to make sure that coverage is happening, not just for the pill, but for all the support services that we've been talking about. And we got stuck and we weren't able to move forward because on this point of the ancillary or support services. And so once the FAQ came out, that day we were able to send it to our Department of Insurance and fairly quickly get a response from them, and they sent out a bulletin to their to the insurers, which is how they communicate with the insurance, saying, "Hey, reminder, you gotta essentially abide by this." So it now obviously there's monitoring and there's things that compliance, blah blah blah, but that was really really helpful, and so I just want to say thank you. Backing up and thinking about just like PrEP and what barriers we've seen. I think the people on this call, this should sound very familiar to y'all, because y'all should, I think, are seeing this as much as we are. But first of all, people knowing about PrEP, what it is, when, like, how can it apply to them, or when to use it, that's a barrier in itself. It's not, I like, even our priority populations that we're talking about. So that's a initial barrier. Then once and if somebody does know about it and they do want it, this cost piece, depending on the type of insurance they have or how they would be able to get PrEP. So if it's Medicaid, if they're older, and if they're on Medicare, Medicare, if they're on Medicare and Medicaid, if they have private insurance, the type of private insurance that they have, are they self-insured? Are they on the marketplace? And then most recently, the thing that came up that we were trying to problem solve was like a student. So they had insurance through their student. I think I reached out to you, Marianne, about this, through their college student health plan, and they were charging them for like some copay or some out of pocket to be PrEP on PrEP, and they had heard that they shouldn't be charging them because PrEP is grade A, and there shouldn't be out of pocket costs. So that's how they ended up connecting with us. So this cost piece, even though we've got this it's a grade A, we've got the FAQ, this cost piece continues to be, there's work that we need to do in certain types of payer areas to actually make it a reality where the person is not having any costs, out-of-pocket costs related to PrEP, being on PrEP. Yeah, I think those are the understanding and the cost piece and availability, I guess, is the kind of the third category. Okay, now that I know my insurance covers it, I don't have to pay anything. I understand what it is. I want it. Like being able, I don't have a healthcare provider that I go to regularly, being able to actually access it when I need it. That's, I think, a third category of barriers. I'll stop there, and others, please jump in.
Yeah, so same, I'll just plus one everything that Nadine just said. I think that there is also room for communication between providers and billing departments and insurers, because there have been state-specific studies that have found that insurance companies do not use the same billing codes as each other, even within a state, for the payment of certain services, including for preventive services that ought to be covered without any copay. And so clarity on how to bill, I think, could also help, especially because it's unrealistic for anyone to expect, to know right off the bat that they're not supposed to expect costs, let alone if a consumer does get faced with a bill, how to navigate that system. If you're already familiar with the insurance company, it gets extraordinarily more difficult if there's a linguistic or a cultural barrier, or if you have limited time. And I think there's also the barrier of kind of insurance transparency. If just looking at the various formularies, it is not always clear whether PrEP is indeed going to be covered without copay. And sometimes insurers will only list the medications used for PrEP on a tier that requires cost sharing, because when that medication is used as part of antiretroviral treatment, it would incur cost sharing. But if it's used as preventive medicine, then it doesn't. And so rather than indicating that in the formulary or describing that somewhere in the formulary, they're simply just keeping the old cost sharing on there. And I think that for the average consumer, it's important to have it clearly indicated so that they know what to expect when they go to the pharmacy. And the same thing for lab testing, is having like a little star and asterisk that indicates if you are getting lab testing as a part of your PrEP regimen, then it should be at no additional cost to you. That should be clear up front, so that people know that there is a difference getting testing for PrEP versus getting testing for some other reason. And I think in terms of making that kind of consistent across the board will be would address a huge barrier, because it shouldn't depend on what insurance company you have to be able to know that. And in terms of other barriers, I will also say there's, I think most people on this call are familiar with kind of the disparities that exist with PrEP uptake and PrEP education and PrEP adherence, especially among Black and Hispanic men who have sex with men, among women. And there's also, other things that kind of feed whether you have access to care or not, right? That's whether you're likely to be employed, whether you're likely to live on an income that's below the poverty level, whether you're likely to face discrimination or stigma in healthcare settings due to your gender identity. All that can impact, kind of be a barrier to PrEP. And even within the kind of the healthcare setting, when people do talk about PrEP with their provider, we still see some disparities as to whether people are adherent or people actually go through with taking PrEP. So I think there's a lot more than just kind of the guidance, a lot more in implementation of the guidance that can help address some of the barriers.
So when
Those are all really great point.
I was going to say just one quick question, just quickly, Kara, because I do want to get back to you. Lindsay, can you please share quickly what insurance is covered by this guidance? Medicare, Medicaid, the Affordable Care Act plans. And then I'm going to come back to you, Kara, to talk about enforcement and what is going on in Colorado.
Great.
Sure. So the guidance I was talking about applies with respect to private insurance. So if you get your coverage through your employer, if you get your coverage on the marketplace, or if you're buying it directly and it's a major medical type of insurance, not these like accepted benefit or short-term limited duration plan, but if it's like a full major medical coverage that is purchased directly from the insurer, it'll also apply. So whether you go buying it as an individual on the marketplace or off the marketplace, it would apply. To the comment about student health coverage, it also applies to insured student health plans. And unfortunately, this is an area where there's a lot of confusion. If it's a self-funded student health plan, it would only apply if they've applied to us for recognition as minimum essential coverage. That's not normally a nuance I would bring up since it's a pretty small group, but it does affect a lot of people. Medicare, I believe, pulls in the USPSTF recommendations, but I think in a slightly different way, and this guidance is not directly applicable to them. And my stuff doesn't touch on Medicaid that much, so I can't unfortunately speak to them, but this guidance is not particular, but I think they also sort of lean into those recommendations in some way, the guidance that wouldn't apply.
Great, thank you. And Kara, at the state level in Colorado, how are you enforcing this new guidance, and what are you hearing from consumers in the state, and how are you responding to their need with the barriers that they apparently may still be experiencing?
Absolutely. That's a great question. And thank you so much for having me today. I want to echo everything that Marianne said a few moments ago. I felt like I was just clapping, saying yes, yes, yes to the issues and the barriers that you were describing. So to combat that, the Division of Insurance passed a regulation in 2019 or early 2020, clarifying that the expectation that commercial insurance companies in Colorado cover HIV prevention, PrEP medication at zero cost to the consumers, and laid out a pretty explicit and pretty comprehensive regulation kind of outlining what that looks like and who it applies to. To the point, though, if you are taking Truvada or Descovy, for example, for treatment, when you look at your explanation of benefits or your formulary or the document that you receive when you're looking at your prescription drug coverage, it doesn't always cleanly and transparently lay out the cost of those two drugs when it's used for prevention versus treatment. So one of the things that the division institutionalized a couple years ago was doing an extensive pharmacy benefit design review as part of its rates and forms review process each summer. We look at medications required to be utilized for each or for a number of different chronic conditions, whether it's prevention or treatment. One of those is for HIV prevention. So what we do every year is make sure that medication is covered at zero cost to consumers. So that way the burden is not on a consumer or a provider to spend a lot of important time arguing, fighting, dealing with the administrative burden of getting something coded appropriately. That will certainly be expanded next year, institutionalized, and currently for on the ancillary services. We have not actually had many to any complaints around coverage issues. I've talked with some colleagues at the Colorado Department of Public Health and Environment who oversees some of the HIV treatment and prevention programming, and other than a couple initial issues around coding and billing, they have not experienced a significant uptick in coverage issues or access, which I think is great news. And the couple instances in which it happened, the companies were notified and immediately remedied them, and they haven't had issues since. I think one of the benefits or the values of kind of our enforcement strategy is that we started this pretty early and pretty aggressively right off the bat in 2019, 2020. So carriers are used to it. They know the expectations. We also have a very robust consumer services section at the division. So we have an entire team that investigates consumer and provider complaints and is there to help support and triage should something go awry, should something be coded improperly. And I think those are really important things. We also have a website, a section on the division's website clarifying somebody's rights and protections around different things, whether that is mental and behavioral health care, whether that's gender affirming care for transgender and non-binary people, whether that's for LGBTQ people more generally. Certainly LGBTQ people are not the only ones who use PrEP for HIV prevention. And so kind of clarifying the expectations, what your rights and protections are, and what you can do if you feel like you or your patient have been improperly denied or charged money for something that should have been zero cost to the consumer.
So the leadership that's been shown by Colorado with their regulations and the information that they've gotten out to patients, hopefully you'll have the opportunity, or your colleague Tara, who we spoke with yesterday with a provider webinar, will have the opportunity to have conversations with the NAIC and the other insurance commissioners across the country and encourage them to engage in similar activities. So yesterday, the Centers for Disease Control and Prevention released an updated clinical practice guideline for PrEP. And a key revision to those guidelines is the recommendation for providers to inform all sexually active adults and adolescents about PrEP. So I'll throw this one out to all of you. What are your thoughts on this revision? And how do you think it's going to impact access to PrEP? And I know, obviously, Nadine, the first thing you said is first you have to know about it, and then you have to have the insurance. So it seems that if you combine the guidance with CDC's new recommendations, we have potential for additional education. So what are your thoughts?
Yeah, I mean, I think I'm not a clinician. The guidance makes a ton of sense to me, though. And I would not expect to see, so to the point that Marianne brought up about uptake, PrEP uptake generally, especially PrEP uptake in Black and Latinx, let's say, communities, people of color, but those specific two populations, like I would not expect a ton of change to happen based on this new recommendation until and unless these other pieces that were brought up are addressed, because they're going to apply whether we're talking about LGBTQ people or anybody else that this recommendation, you know what I mean, that this the recommendation applies to. So from my perspective, it makes it even more important to try to get ahead as much as possible of these issues that we clearly know about, the coding issues, any prior auth related issues, because they're going to apply to more people with this new advisory recommendation that came out yesterday. Mm-hmm. And I'm not a clinician, so.
No, that's fair.
I'm not a clinician either, but I would highlight that we did have a webinar with clinicians on it yesterday that was kind of targeted to healthcare providers. And I think one of the biggest takeaway messages is that PrEP care is not specialty care. And so the more that we can kind of make this kind of a standard part of talking with your physician and talking about sex, and the better the uptake will be around PrEP. And the other thing I would also highlight is that the U.S. Preventive Services Task Force is already underway with updating its PrEP rating, and one of the topics that they will be reviewing, along with whether newer PrEP regimens like injectables or the vaginal ring is going to be it has some kind of clinical benefit that's greater than other regimens, is also looking at kind of the risk assessment tools that people use, that clinicians use to identify people who should be taking PrEP. So I think that looking forward, that's something that the USPSTF is also going to be considering.
How can we make sure that other stakeholders are aware of the new FAQs and their implications for coverage of PrEP ancillary services? Because that is going to be key to uptake in some communities, not all of them, but what is being done advocacy wise in that regard? How are folks, how are organizations getting the word out in communities that are most impacted?
One thing that is happening in Colorado is every year, the One Colorado Education Fund, which is an LGBTQ advocacy organization, they published what's called the Transgender Health Insurance Buyer's Guide. And a few years ago, that guide was expanded to look at how HIV prevention and treatment medication is kind of designed on a formulary, and they also did the same thing for hormone therapy. So what this very publicly available and widely publicized tool does is it reviews and analyzes all of the services and medication that somebody may need while they're shopping for health insurance. It is only based on the commercial individual market, so the statewide exchange. But what it does is analyze each plan, each coverage by each carrier by carrier next to each other, and looks at the ways in which medication for HIV prevention and treatment is tiered, therefore the cost that should be expected out of pocket, roughly. And that's really helpful, one, for insurance literacy. We've talked a lot about lack of transparency in accessing care, prevention, or treatment. That's really helpful for increasing insurance literacy and consumer education as someone is looking to purchase insurance for themselves for the upcoming year. It's also a really helpful advocacy tool, not just for community advocates and organizations and providers. It's also helpful for regulators like the Division of Insurance, because it can look at a tool like that and see pretty cleanly and pretty easily if there are other violations of state regulation or statute. We have another regulation around non-discrimination protections in formulary drug and benefit design. And so while that is something that we certainly look at internally, and we have institutionalized doing so, it's also another way that can spread awareness and spread understanding about one's rights and protections while also ensuring better access to care. There are shortcomings of a tool like that. It is only for the insurance, the individual market. It doesn't look at other types of commercial insurance, but I think it's a great step, and I think that's a tool that can be modeled for other chronic conditions as well.
That's wonderful. That's that's great news. So quickly, Lindsay, can you tell us a little bit about what SOCIO and HHS, how are they going to be enforcing the new guidance? What will happen if complaints come in about a particular carrier that they are charging patients still out of pocket costs for the ancillary, for the follow-up blood testing, for instance? How does the agency respond to those types of complaints?
Sure. So I hinted at this at the very beginning, but the reason I mentioned that Labor and Treasury were also involved is we share kind of oversight with those agencies and states as well. If it's like a group health plan, the Department of Labor has the lead. We work very closely with states because in all but 4 states, the states are the primary regulator and enforcer of these rules. So while we issue the guidance, the states are the ones who largely enforce it, and we work very closely to answer any questions we get when issues like this and ambiguities are bubbling up. We try to address them, and then we do enforce in 4 states and also over what are called non-federal governmental plans. But so when we receive a complaint, we first figure out who that complaint should go to. If it's where we are enforcing, we will certainly take a look at it and investigate it and see what needs to be done, whether there are corrective actions or whether there needs to be some sort of penalty involved. But we'll investigate it. If it doesn't belong to us, we make sure to route it to the appropriate regulator, whether that be the Department of Labor or our state counterparts who would take the lead if it's like a health insurance issuer. We also, there are entities that operate in multiple states, whether it be a third-party administrator or a health insurance issuer that might have presence. And so because of our role kind of working with a lot of states, we can also see as some of those issues bubble up, and or if we're working on a investigation with respect to a non-federal governmental plan and see that this is somebody who touches a lot of different areas, not just the investigation we're looking at. We'll try to look at it a bit more broadly because we'd rather take a more holistic approach there.
That's helpful. So what role does PrEP play in the advocates and government efforts to end the HIV epidemic, and what is the interplay with the national HIV/AIDS strategy? Would you be able to speak to that, Marianne?
Yes. So clearly, a core pillar is preventing, and that is prevention, and that means making sure that everyone, regardless of what insurance they may have, or even if they're uninsured, that there are avenues to get and stay on PrEP. I think thinking about it contextually, it also means making sure people feel comfortable talking with providers, that they stay engaged in care, and that they have a safe way to access lab testing and access the actual medications, especially people who may not be public with their sexual activity, sexual orientation, or live in a setting where everyone knows when you go to LabCorp or Quest Diagnostics. I think another thing to also keep in mind is kind of because this is such a core pillar to ending the HIV epidemic strategies, both from the federal government and from advocates, is to remember like why we're able to get this coverage requirement, and that's because of the Affordable Care Act. And there is currently a case in the Northern District of Texas that is challenging the federal government's for the ability for the federal government to determine what preventive services ought to be covered without any additional cost sharing. And currently sitting before a judge that has historically made decisions that were either invalidated the ACA or invalidated certain interpretations of the regulations. And so I think, it's important to just generally defend access to care and the laws that authorize the federal government to make these requirements. But also, I think long picture, if we can kind of expect the possibility of uncertainty going forward, it just kind of makes it all important now to make the coverage of PrEP and ancillary services a default for insurance, so that even if, knock on wood, there's a question as to the legitimacy of these requirements, that it is already set and already kind of the default option for plans to provide this coverage without copay. And which just kind of, I think we all know its place in this strategy, but I just kind of wanted to also emphasize the importance of having that be a permanent part of the strategy and something that can exist outside of legal challenges.
Sure. Going back to the point of education, just quickly. So Lindsay, in light of yesterday's announcement from CDC, and obviously you, HHS and SSIO have put out the FAQs, what efforts have been underway, or do you anticipate down the road for further education, either to the provider community or to the public as a whole about these recent changes, so that they have an opportunity to be aware of the change and how it may benefit them? Because provider education was definitely something that came through very loud and clear for us yesterday. One, just because providers need to be doing more in this space, but then two, they also need to be aware of the changes in terms of coverage.
Sure. So unfortunately, I don't know that we have any sort of strategy for making sure that from the federal government that we're communicating this proactively to providers. But a lot of this conversation has had me thinking about the No Surprises Act, which passed almost a year ago. And there are a number of provisions in there related to transparency. And as I've been listening to everyone talk, I've been trying to think about how that can really be leveraged as we move forward. As an agency, we've really been focused on a number of the provisions in that act related to balanced billing because of the real immediate nature of that, and what we see as the real kind of, there's such consumer protection there that we want to make sure that it launches on January 1st. But there are requirements related to providers disclosing, providing good faith estimates that for uninsured and self-pay individuals will be in effect on January 1st. But then, and we've currently kind of deferred enforcement for a good faith estimate to be provided to insured individuals. But in the long term, that should allow somebody, when they go to schedule care, to get an estimate of what their out-of-pocket costs will be. They'll actually get it, their provider will be required to disclose the information to their plan or issuer, and then the plan or issuer will have to tell them not just what the provider is billing, but what their out-of-pocket is going to be, which I think we're going to be looking as that rolls out and really goes into effect at a whole set of new challenges related to consumer education for how to navigate these kind of new rights and make sure they're taking advantage of it. But I think it also presents a huge opportunity for people to be able to get that information and to be able to see, here is, I will pay $0 for this service. And I think it'll be important for us to really be thinking about, I've heard a lot of the challenges around coding. We want to make sure that estimate for an antiretroviral represents the cost that should be assigned when it's a preventive service, not when it's for treatment. And those challenges we'll need to be thinking carefully about. But I think that as we see those new laws go into effect, really could help with a lot of these transparency challenges.
No, that's a good point. So I think our time is getting close to winding down. As you can tell from the discussion today, there are a number of opportunities as advocates to get involved in helping with education and either about PrEP or about the FAQs, and to share additional information. But beyond that, Marianne is going to close us out with another important action step that advocates can take with regard to legislation that's currently pending on Capitol Hill. So I'm going to turn it over to you, Marianne.
Thanks. And I believe we have a slide to share as well.
Here we go.
While we have established government programs that are funded to provide treatment of HIV and provide HIV care, we also need a comprehensive nationwide program that's dedicated to the provision of PrEP. And allies on Capitol Hill have worked to draft legislation that moves in that direction. And there are two bills that we just wanted to highlight: the PrEP Access and Coverage Act and the PrEP Assistance Program Act, recently introduced in Congress. Establish programs to provide states, Indian tribal governments, federally qualified health centers, rural health clinics, local governments, and community-based organizations to establish and support PrEP programs. The first of the two, the PrEP Access and Coverage Act, is actually a little bit broader in scope. It would eliminate out-of-pocket costs for PrEP and associated services, including lab fees, for all forms of insurance, would prohibit prior authorization requirements for HIV prevention drugs under private and public health insurance programs, and also invest money in public and provider health education programs to increase utilization of PEP and PrEP. I believe that there will soon be a letter that will be circulating around various advocacy groups, so keep an eye out for that. And we would encourage that if your organization has a strong relationship with a member of Congress, to talk with them if they are not already a co-sponsor of these important HIV prevention bills. With that being said, thank you so much to our panelists for joining us on this webinar. Thank you to everyone who joined in to listen in. This recording is being recorded and will be made available online, and so we will follow up with the recording and other helpful resources. Thank you to those who have dropped information and questions in the chat, and I hope everyone has a safe and relaxing holiday break. Thank you.
Thank you.